coming out of the various questions and comments that have been made, so you'd like me to speak about those. There was, I think the first person said something like, well, where does primary health care fit into the curriculum, and should it be here or there or everywhere, that sort of thing. From my perspective, that's not the issue. The issue is that medical students, in my observation everywhere, are ambitious high achievers. They want to be the best kind of physician they can be. And it's about role models and mentors. So if the experience that the medical students have is in big city teaching hospitals, where the senior teachers are specialists and subspecialists, that's the kind of physician they want to become. So what's important to make things different is that the students, particularly early on in their education, have lots of time in the primary healthcare setting with positive role models who are primary care practitioners. And so that's how that's the beginning of students choosing primary care as a career pathway rather than the current focus on specialties and subspecialties. Somebody asked a question about experience of what we were talking about in a low-income country setting. Now, Northern Ontario School of Medicine is a member of the Training for Health Equity Network, which is a group of schools around the world where the whole institution is driven by a social accountability mandate. And we have, many of our schools are in low-income countries, but just one example in the Philippines, in a place called Zamboanga. Zamboanga School of Medicine started actually in 1994 as a result of a widespread community movement which says if we're ever going to turn around the shortage of doctors and improve the health of our people, we need our own medical school. Same story as in Northern Ontario, but 10 years earlier. And you have to remember, of course, that in the Philippines, in the traditional medical schools, 60% or more of the graduates leave the Philippines the day they graduate. Okay, so just two statistics from Zamboanga. The first is that over 90% of their graduates are not only still in the Philippines, they're still on Mindanao Island, which is the South Mindanao, which is where Zamboanga is. Many of them practicing in communities that never had a doctor before, like in villages in the jungle. The other is that before the Zamboanga school started, the infant mortality rate was 80, is it per 10,000 or 80 anyway, and now it's less than 8. Now you can't make an absolute connection between the medical school and the reduction of infant mortality rate, but it's likely that the existence of the school, the students learning being in the communities, has helped to improve the health and the infant mortality rate. Which brings me to the next point that somebody made a comment about. Is it all just for the students gaining by being in the primary care setting? And in fact, it very much is a two-way street, was the term that was used, and that's the way they talk about it in Zamboanga is that the students learn from the community benefits from the school, and the community shapes the students. So it's very much, and that's certainly our experience in Northern Ontario, as I said, that it's a mutual benefit for the community and for the learners in that community. There was a comment about the community health practitioners, and they've graduated from traditional schools, and so they're not necessarily comfortable or confident to take on a teaching role because their experience of teaching was what they had in the big city teaching hospital. And that's certainly a challenge. What I found is first of all, it's important to help these practitioners to recognise the parallel process between the patient-doctor relationship and the learner-teacher relationship. So these doctors, generally through their interactions with patients, have developed a lot of skills which are really teaching skills that they don't give themselves credit for. So the first thing is to give them credit for what they already know, but they don't give themselves credit for. The second, in helping to establish this kind of model where the community practitioners are the primary teachers, it's very important to have community participation. And when we were starting in Northern Ontario and saying we wanted our students to spend the whole of third year in these communities, many of the physicians were quite reluctant. You know, it was different from the model of education they were used to, and they were anxious about having responsibility for these young future physicians. The community members had no reservations. It made perfect sense to them to have the students learning in the community that they're going to serve. And so the expectation of community helped our physicians to take the plunge. We certainly did provide extensive teacher training, faculty development, so that they were prepared. And what I found was that even just after 1 year, many of the physicians who had been quite hesitant beforehand were completely converted. You know, several of them came up to me and said, you know, I was really doubtful before, now I'm a convert. So it's the experience of interaction with the students and support from the community makes this work. And the point that was raised about continuing education, and that including teacher training, faculty development, that is very true. So it's important to build that into the model as you're developing this kind of community education.
We learned earlier, I think yesterday, that medical care is really only a small part of the many factors that determine the health of individuals and communities, and that the most important factor contributing to health or ill health of communities is behavior. And we need to find better ways to do something about that. So tobacco abuse is a huge problem all around the world. Obesity is getting to be a problem all around the world. Traffic accidents are a problem in many countries. And these are all things that are not really amenable to medical care. They are amenable to we're not sure what. That's why we need research. We need research done in communities. But communities are not interested in being studied. They have had many bad experiences with universities that come to do research and then exploit them. I'm not sure if everybody in this room is familiar with the Tuskegee study. That's a famous instance in the United States in which a community, an underserved minority community, was badly exploited by actually government researchers. Perhaps the research in the Guatemalan prisons has received more attention here in Latin America, another instance of very unethical behavior. So we have begun to practice community-based participatory research. And we say that the community is no longer to be a subject of research, the community is a partner in research. And the community is to partner in every phase of the research, identifying the topic to be studied, identifying the method by which it will be studied, conducting the actual research, gathering the data, interpreting the results, and disseminating the results. And we have, at Morehouse and many other places, we have been able to employ this very effectively. And somebody referred earlier in the talk to Paulo Freire, the Brazilian educator who worked with underserved communities and used education as a tool for lifting up those communities. And we've tried to apply those principles to doing research and have been able to achieve some community development through the research process by empowering communities to have some say over how research is to be done in the communities, where it is to be done, and under what conditions. So this is probably something that needs more discussion among these various schools that are gathered here and other schools like these. I attend many meetings like this, and we are all in favor of the same things, and we wind up talking to each other, and perhaps the people who most need to hear what we have to say aren't here. And the same thing may apply to research. We need to all get on the same page ourselves, and then perhaps we can bring others into the meetings and transmit these ideas to others who need to hear them. But those of us who are interested in community-based medical education need to also be interested in community-based participatory research, because it employs many of the same principles and can have many of the same outcomes and can have even more of an effect on the health of communities than can the community-based medical care that we've been discussing.
Y así breve, ¿no? Si nosotros vamos con la presentación de Reinaldo Older y la propuesta de sistema de salud basados en la atención primaria de salud, como él lo ha presentado, el concepto de redes integradas, donde en principio usted tiene una propuesta de ordenamiento de un sistema de salud basado en un conjunto de valores que él fue comentando, de equidad, de solidaridad, etcétera. Usted podría representarse de manera así simplista un sistema de salud que es una pirámide, como las pirámides de Keops, ¿no? en Egipto, que tiene una base muy amplia, un primer nivel de interacción con la comunidad y el servicio de salud muy amplia, y después, en la medida que usted va entrando en niveles de servicios, en conjuntos de establecimientos especializados, donde usted tiene, digamos, de la población, los que llegan al tercer nivel de atención será un 2, un 5% en un momento crítico de su vida, ¿no? Y si nosotros pensamos, digamos, ese sistema de salud basado en la atención primaria con esa pirámide, yo diría desde la perspectiva de la fuerza de trabajo médica, tenemos un problema fundamental en nuestros países, que es la composición de la fuerza de trabajo médica, porque tenemos la pirámide al revés. Entonces, estamos viendo de las residencias médicas 6% de las plazas en 11 países de América Latina de medicina familiar, y la pirámide va hacia arriba, ¿no?, de las especialidades. Entonces, yo pienso que en relación a la pregunta que usted hizo, que toda persona que entra en estudio de medicina, si es que hay una voluntad nacional que coincide con la estrategia de atención primaria como no fue presentada, todos los médicos tienen que empaparse de lo que es ese modelo de atención que se está proponiendo, ¿no? Y uno tiene que ubicarse dentro de ese sistema. Y ubicarse dentro del sistema, eso quiere decir que yo no necesito de un oftalmólogo con 6 o 8 años de medicina, 4 años de especialización para tener anteojos, ¿no? Tenemos una serie de ineficiencias, pienso yo, en nuestro sistema de salud, porque en términos de las prácticas profesionales, la pirámide está invertida y se vuelve, por supuesto, el sistema de salud, yo pienso, en el futuro muy difícilmente sostenible en términos aún financieros, con, digamos, la emergencia de las crónicas. Es decir, yo digo, todos los médicos deberían de entender, si por ahí va, como en algunos de nuestros países, con un modelo de atención primaria donde que sean médicos especialistas de primer nivel de especialidades generales hasta las más sofisticadas, y eso daría para una larga discusión sobre las nuevas tecnologías, los tratamientos autoadministrados en los domicilios, el rol pero yo pienso que un problema fundamental es eso, es la composición. Entonces, eso quiere decir, todos los médicos que tienen que entender un sistema de salud basado en la atención primaria, y dos, nuestras facultades, en mi juicio, tienen que contribuir a revertir esa pirámide de la fuerza de trabajo médico. Quiere decir que también implica un compromiso con la formación de médicos con una orientación de salud familiar, o del primer nivel de atención, o de cómo lo queramos. Porque es interesante, los canadienses no hablaron, pero los médicos de familia en Canadá, que es más del 50% de la totalidad de la fuerza de trabajo médica, tienen roles en obstetricia, tienen roles en anestesia, los utilizan en las zonas alejadas como mini especialistas, los forman para eso. Entonces se vuelve también el médico de familia una capacidad para absorber el primer nivel de atención, pero que también está articulado con los demás niveles. Entonces yo diría, eso es el segundo tema. Tiene que ver con la distribución, pienso yo, ¿no? La pregunta que usted hizo sobre la experiencia de no notario, realmente eso es una estrategia, pienso yo, de formación de médicos en ese caso, para ver cómo logramos atraer jóvenes de las regiones subatendidas y de cómo generamos un proceso de formación que favorezca que se permanezca ahí. Eso es un problema de distribución, ¿no? Y últimamente de acceso. Entonces, yo diría, la respuesta es, no formamos médicos únicamente para el primer nivel de atención, pero hay que buscar cómo restablecemos un equilibrio. Eso quiere decir cómo revaloramos la práctica de la salud familiar y de la medicina familiar y comunitaria, ¿no? Pero yo pienso que la educación médica hacia la atención primaria tiene que ver con el conjunto de los estudiantes de medicina, no son únicamente los que tienen como intencionalidad de acceder al primer nivel. Ahora, yo no sé cuántos países nuestros tienen una meta en términos de la proporción de egresados de medicina que quieren que vayan en medicina familiar o en medicina general. Entonces sería interesante dar la vuelta aquí y preguntar a las instituciones nuestras, ¿tienen algún objetivo en cuanto a qué proporción desean ellos de sus egresados que fueran en medicina familiar o en salud familiar? Yo pienso que eso es el elemento importante para posibilitar un sistema de salud basado en la atención primaria en países donde, como yo les digo, la pirámide en términos de la composición de la fuerza de trabajo está invertida, ¿no?